We'll explore into the current perception and knowledge regarding frontiers in emergency and trauma care, innovative system and practices.
She completed her graduation and post-graduation at CMC Vellore and hold doctoral degree in INC Consortium. Also hold a master's in sociology. She is gold medalist and best outgoing student in BSc and MSc nursing. She has attended and presented papers in 6 states and also in national and international conferences.
She is guiding MSc nursing students and PhD scholars, has been a resource person in several conferences across the world. She is the author of 15 research articles and Madam created a nursing process module and serving as a mentor across India. Welcome, ma'am. The stage is yours. As we move on to the next session, all delegates should come back to the conference stage.
A very good morning to one and all. Good morning, everyone. Yeah? All of you are back having your tea? Yes? Okay. At the outset, any conference, this is my first slide. I thank the Lord for every great opportunity He has been giving me. And also, I would like to thank Maheshwari ma'am and her team. I told her in the morning, this feels like my second home. Okay, thank you so much, ma'am, for giving me this wonderful opportunity. And not a doubt, it is purely God's grace. His grace that we are here today. Yes, and I hope all your faces are like this. Yes? Okay, good. And this is yet another very beautiful quote. There is nothing called as a good day or a bad day. It all matters the way you look at it. If you look at it as it's a good day, it is going to be a good day. And if you see that it is a bad day, it is going to be a bad day. It is your attitude. And I hope and pray that you are sitting here with the right attitude, that as ma'am said, when you get back out of this room, that you will go with a spark in your mind. Hey, come on, why don't I do this for my patients? And I pray that that would happen. Okay, and yeah, rewiring your brain. Wantedly, I put this because innovation is our topic today. We are all so glued into the digital. Everything we keep typing and everything. Handwriting is gone, right? But to rewire our brain, we have to keep thinking, it seems. What am I grateful for? Can you just close your eyes for a moment and think 3 things that has made you, that you are truly grateful for, which is really going to make you happy. And with this happiness, if we move forward, I think, the classes or, the topic that is given to me is going to be very, very useful. Right? You can open your eyes. Rewire your brain. I always, think this. We are so digitalized, technologically advanced. Whether we are technologically advanced or not advanced, to hold the audience, the concentration of an audience is the key. Right? Are you all ready for that? Yes? Okay. Some kind of exercises for your brain. Right? We are so used to sit and listen to somebody. Oh, yeah. Okay, I just love the brain teasers. Okay? Yeah. Just find out the phrase. With the way the pictures and the words are arranged, just find out a very famous phrase. It's a phrase. Just get up. You have to get up. Again, that's the exercise I want you all to do. Here there is one person with the answer. Yeah. Yeah, give her a big hand. How many of you, got this answer right? I want you to come up. Just come up, yeah? Once upon a time. How many of you got it right? Oh, yeah, good. Hey, come. Can you come a bit faster? That's the way I, kind of hold the audience, right? Give her a big round of applause. Okay? God bless. Okay. Just look at the second thing. Oh, yeah, I can't give everybody, right? First aid, yeah. This one? Yeah, Jenny, come, Jenny. Yeah. Think out of the box. Think out of the box. Okay, and that is what innovation is all about. Innovation is all about that, right? Yeah. Think outside the box or out of the box. Yeah. I am on the top of the world. Who told that? Yeah, because at Vellore, this is a very famous song. I am on the top of the world. We had sung this song, okay? Yeah, I am on the top of the world. Are your brains rewired? Oh my God. Yes, it is rewired, okay? Yeah. Just find out 6 words from this puzzle. No, you have to come forward and just, what I'm trying to do is get your attention, to be alert. If you have the answers, come, quickly run and come forward and point out. No, don't say from there. Just come forward. Anyone? Yeah, that's right. Come. I want volunteers to come forward. Or you want me to put the answers? Yeah, come forward, please. Because we are running short of time. But yeah, give her a big round of applause. Yeah. Yeah, thank you so much. Thank you. Yeah. Just show it, no, point out. Laugh. Yes. Cow. 2. Okay, 1 minute. Okay, yeah. God bless you. Okay. Owing to time. Just look at that for people who said, I know. Okay. Orange is there. Guitar is there. Right. Wow. Right. And we have Iowa. We have laugh. And we have cow. Okay. Rewiring your brain is very, very important in this digitalized world. Okay. Because our brain is wrongly wired nowadays. Okay. So, yeah. Fine. I'm just, want you to give me the full attention because that is the highest form of reverence that you give it to a person. Right? Yeah. This is a topic that is given to me. And ma'am, you really helped me to research more, actually speaking. In and around the world, what is happening. Okay, thank you. And I hope that I'll do the justice. I'm just starting with a slide like this. Healthcare landscape is changing. Okay, because of the patients are very complex today, shifting demographics, the age geriatric population is more, right? And it has become more digital, more data-driven. We are talking about more data-driven, more demanding on quality and safety, right? We have the NABH accreditation, JCI and whatnot, and more multicultural and international. All these and even many more. This is what just came to my mind and I have put it. All these are changing the landscape, healthcare landscape. And, it has become more people-driven, social, if you see there, personalized, right? Today people are talking about personalized, nutrition and all that, digital and everything. So it is keep changing. The healthcare scenario is keep changing. And there is a paradigm shift. What suited yesterday, not necessarily it has to be today. There is a complete paradigm shift in terms of healthcare. And, it has changed from one way of thinking. Today, what I think may not be right for tomorrow. That is what I call it as a paradigm shift. And, how our future holds. We need to, analyze, keep analyzing the changes that is happening all around us. That is what is going to make us ready and help us to innovate. And I just love this picture, right? Paradigm shift. And look at that corner there. It says, lead the way, turn the challenges. Every day is going to be a challenge, right? Into triumph. And this gap, I want you to see this. Any innovation that is going to come, when you want to put it into practice, there is going to be a gap here, right? We need to understand it is not going to be easy, right? And as ma'am said in the morning, it need not be very costly. I truly believe in that, ma'am. Innovation, right? Fine. And all these are the terms. It is a challenge. It is going to be divergent, rethink. There is going to be a lot of criticism with the innovation that you're going to make. All these are true with innovation, but it is happening. Fine? And remember this. Innovation. There is nothing permanent except change. We have to be ready for that. Right? Yes. And embrace the change. I'm just trying to put in the values that are needed when I'm innovating something. We need to be in a mindset to embrace the change. And new mindset will help you to come with new results. You have to keep asking, what is wrong in this situation? Only then, you'll be able to come with a new solution. And if you are, brave enough, you will take up the innovation and you'll keep growing, embrace the change. But if you think that it is not needed, you're going to find, if you're going to give excuses, you're going to deteriorate and fall. Right? Yes. So embrace change, adapt quickly. I just love this, the animation. Okay? For any innovation to come true, we need to live our comfort zone, right? Only then, you'll be able to achieve success. Okay? If you are very comfortable, okay, I am, okay with what I am doing. This is enough. Okay? I am comfortable. Okay? We are not going to achieve success. Right? Fine. So, with that, I just wanted to put one more thought into your mind. What is the core of nursing? If you ask me, clinical practice is the core of nursing. Right? Education is attached to it. I am educating a student to become a good practitioner. And I do everything. Every research should focus on bringing up the patient care. And whether in informatics, lot of things are done with informatics today. Even that has to focus on practice and, the nursing administration. So the core is practice. Okay? I can never be a good academician if I'm not going to be a good caregiver. I want you to understand this because this is a scenario. Innovations, every innovation, whether it is in the education side or whatever side, it has to finally come and, prove that your practice is going to improve. Right? Yeah. Yes, just to, kind of say that it is important. Now, I'm moving on to the challenges in the emergency department. Right? I wanted to make it interactive, but I think owing time, just look at this. One is the overcrowding and patient flow, where, there is an increasing patient volume, long waiting times. Sir was telling in the morning, people queuing up to see patients, and access blocked due to unavailable inpatient beds. Until a bed is, you have to wait. Delayed admissions and discharges and ED boarding of admitted patients. So the first challenge is overcrowding. And the second is, workforce shortage in terms of nursing shortages, physician shortages, staff burnout and fatigue, and high turnover rates and workplace violence. Because many of my friends work with accident and very active people. But again, at the same time, highly burnt out. Okay, because, it is a very, kind of a very challenging area to work. And clinical challenges. Many clinical challenges where, you have to manage critically ill patients from all specialities. That is one thing. Rapid triage, diagnostic uncertainty, whether this is right or wrong. Time sensitive, you can't waste any time. That's a big challenge. And the medication safety is yet another thing. There are many challenges, but these are some clinical challenges. And we have resource and infrastructure challenges. If you look at the resource and infrastructure, bed shortages, equipment, we take our students to GH. Lot of, equipment shortages, right? We do need to agree. I'm not talking about the corporate sector, right? Space constraints. ambulance delays, and supply chain issues. So there are resources challenges, and we also have communication and coordination because it's a multidisciplinary people working all together. So if you see here, we have poor interdisciplinary communication, delays in specialist consultation, we have to wait, inefficient handovers and fragmented information system. So that is yet another challenge. And we have technology and system challenges where everything is now, electronically, or digitally everything is made. So we have EHR integration is a problem, cyber security, limited AI use, and, there are a lot of problems with the technological use. And apart from that, adding on to this, we also have emerging challenges. What are the emerging challenges? If you see here, we have aging population, geriatrics, increasing mental health emergencies, opioid and substance abuse crisis. We have infectious disease, and climate-related and mass casualty. These are the emerging challenges. And because of all these challenges, there is going to be delays in care, increased errors, mortality is high, staff stress and burnout, poor patient experience, and higher cost. These are some of the reasons why innovation is very, very important in emergency. Right? I hope you agree with me. Okay? Yes. I just love this animation. Okay? Be ready for the change, to be flexible, adaptable, and to innovate. You need to break the barriers. You need to break the challenges for the innovation to happen. Importance of innovation. Why innovation? Ma'am was, rightly pointing out in the morning. Improve the patient outcomes. We all know this. I'm just quickly going through, okay? Enhance the patient safety to increase the efficiency, address the healthcare challenges, support the digital transformation. Please remember, everything is digitalized. You know it or not knowingly, somewhere or the other, AI is there everywhere. So digital transformation, innovation is very important to strengthen the clinical decision making, promote cost-effective care, empower nurses and expand access to healthcare, and prepare nursing for the future. But ultimately, quality patient care. Quality patient care in the emergency department. Just keep that in mind. Okay, that is the core word that I want you to remember. So if you see this, what are the current and future solution in the ED department? What are the types of innovations? If you see here, everything is AI assisted, and we have point of care diagnostics and ultrasound, and we have tele-emergency medicine, smart patient flow management, predictive analytics for the overcrowding, drone delivery of blood, medications, and AED, not in our country, but it is happening all around the world, and robotic assisted logistics, real-time bed management systems, wearable monitoring, and digital dashboards. There are many, many of this that I have listed as AI assisted. Please don't think that, innovation has to be only with AI assisted. It can be simple things. Yesterday we were traveling by, one of the private buses. I just loved one innovation that was made in the, whenever I used to travel, the curtains used to kind of flow and, what they have done is now they have put a bar. Simple, very simple innovation that just took out the, the problem. It is not AI assisted. I felt very comfortable. I really appreciate that innovation. Simple things, okay? Yes. Now, we are going to move and see what is the first innovation. I've just put some 4 or 5 innovations. There are many actually speaking. The first is AI-powered clinical triage. In India is happening. I just came here and I was just seeing, where in India. It is happening. It is happening in, in Kerala. It is there. It is there in Noida. Many parts, we have integrated AI. And if you see here, what is the triage? It is the right patient to the right place, right time with the right care provider. And that's what triage is all about. Fine? And, these are some of the traditional triage systems. These are the challenges. We are not able to manage with huge workload, huge number of patients. There is a chance of error. The staff gets burnt out. All these are challenges with the traditional triage. And this is how the AI triage looks. Patient data is, kind of stored, and, the AI processes it. Whenever a patient is received, It processes and the triage decision is made and improved. For this is very important. Lot amount of data is already needed for the AI triage to make the right decisions. I'll come to it later, why this is very important. And look at this. This is yet another picture. It's not just at the triage level. Even in the pre-hospital level, it is connected. AI is used. We call the ambulance, right? 108, we call the ambulance, right? And every data is stored. The information is given. We have in Tamil Nadu something called as the Tamil Nadu Accident and Emergency Initiative, Emergency Care Initiative. Beautiful. Every data is stored. Pre-hospital. Sometimes even the pre-hospital information or guidance is given. So the triage, not alone at the point of triage, it happens even before, right? We have high-tech ambulances nowadays, very high-tech ambulances where, the data is used. And, investigations at the point of discharge and treatment. At treatment, again, lot of wearable monitors are used. Okay, kind of, you put the patients in the ED before you go, transfer the patient. You want to monitor. You can't go patient by patient. So they wear wearable monitors. It is introduced in, like in the ED. So AI uses right from pre-hospital care till the point of discharge. I want you to understand that. And this is how the triage, the traditional triage, and this is how the traditional triage information is loaded or the data is stored, and the AI, it is modeled. Please remember the word modeled. AI is something, it is modeled, it is trained. So when you get that kind of case, an automatic triage can be done and patient can be given a severity index. Yeah. So what are the advantages? Faster care, better decisions, smart usage of resources, and we are supporting staff. AI doesn't do it on its own. It needs supervision. It is done along with human judgment. Please remember, I want you all to take home messages. AI with human judgment, human clinical judgment, right? Yes. So there is, I'm just skipping this owing to time. So it starts from even self-triage, we do it. What do we do? When there is a symptom, even we ourselves we do, right? What do? We Google it or we put it in a chat GPT. Do we do that? How many of you do that? I did it, 3 or 4 days back when not for me, but for someone else. Do we do that? Yes. There are a lot of applications even for that. Okay? Where hospitals are using for people to not self-triage along with the hospitals, and they say whether it is serious enough to come to the hospital. You got it? So, we have right from self-triage till discharge. Remember that? Various apps. This is in 2023, where ED triage, we have lot of, apps that is available. Similarly, for self-triage, we have so many apps, and similarly for EMD, we have a lot of apps. It is there. It is living with us. Only thing is, I have to use it very judiciously. I'm talking in terms of evidence because it's all about that. If I talk all this without evidence, it's going to be a waste. I've taken all systematic reviews where already conducted lot of studies has been analyzed. It's called as analysis upon analysis. So if you see here, this is a systematic review on the impact of artificial intelligence-based triage, where around 6 studies. They initially, they took up somewhere 119, and then finally they chose 6 studies. And if you see here, I want you to see this. Reduced triage time, improved triage accuracy, and lower mistriage rate. Got it? This is what we are looking at the triage, and non-urgent cases were identified appropriately, where we assign priority 4 or priority 3. Those cases were identified appropriately. Isn't that nice? Yes? When used very judiciously. And this is second evidence. This is a nursing study. Look at that. It's an artificial intelligence technology-based medical information processing and emergency first aid nursing management. I'll just quickly say what it was. Around 120 pre-hospital emergency management system, those data were stored, okay, and it is transmitted to the emergency workstation, that's the triage, and because it is AI based, whenever there is a new case, this emergency AI triage workstation, that person was able to do the right thing. How? Either, that a patient is triaged into the first, second, or third category, or, the person gives information to what to do in the ambulance, two things, and rightly managing the complications, okay, and the further those information is stored. And look at this. This is the effectiveness. If you see here, this is the success rate of how the complication was managed. 96.7% of hemorrhagic shock was, adequately, kind of treated because of this AI triage. And look at this. This is a 3 years. They did the study for 3 long years where, the first stage success rate improved, from 91.8 to 94.2. And the triage time, in the experimental group, the triage time was much, much lesser because it was AI based. Okay? Yes? What do you would take home message? AI plus human clinical judgment. Okay? Never forget. We can't leave everything to machines. I'll come to it later, right? Fine. This is what I want to say. These are the plus. Right? These are some of the studies. 27% reduction in sepsis and all that. But again here, AI missed out certain data. That also can happen. Okay? I just wanted to, kind of give one example where AI got everything right. There was a patient, okay, probably it might not be that exact, but what I understood. Okay, there was a patient who got into the emergency department with a flu-like symptoms. So the nurse in the triage thought that it's flu-like and gave a priority of 4 to wait. But there was an AI tool for sepsis sniffer tool where it analyzed the vitals of the patient, also the lab details, and the sniffer tool said it disagreed with what the nurse did. And it said the AI calculated a 71% probability of septic shock within 2 hours. So the alarm was sent to the doctor, but the doctor kind of, neglected it. But the alarm, what happened is, from 71%, okay, the chances went up to 79 to 84. Then the doctor alarmed, okay, and shifted the patient to a monitoring bed, to ICU, and saved the life of a patient. Where AI got it right when humans did not. That can happen. Similarly, where AI could go wrong. 74-year-old patient, sorry if the age is right, but I'm trying to say, felt something like indigestion, but the AI did not have data on older patients. Okay, so the nurse assigned a priority again of 3 or 4, but indigestion-like symptoms can be a chest pain. Do you know that? The patient had a massive MI. Massive MI where after 90 minutes the nurse went and saw by the time, most of the heart muscles were dead. The AI misguided the nurse. That also could happen because that AI was not trained for the 80-year-old and 75-year-old of MI. So what happened in that particular hospital in Australia, this happened in 2 patients and they suspended the use of AI. That also could happen. We have to be very, very cautious, judicious use. So if you see, I'm just skipping this slide due to time. Just remember this. Refine the AI algorithms. Integrate the wearable technology, clinician education, ethical. See, you need to use your judgment along with AI. That's a simple message that I wanted to give. Right? So that's the first innovation. I'm moving on to the second innovation. Okay? And it is unmanned aerial vehicles. All of us are now, you ask the youngsters, they are so happy with the drones. Right? So happy with the drones. Okay? But this is used very effectively in emergency care. And see this? This is again a systematic review. I love systematic reviews because they take up a lot of articles, already research that is done. So if you see here, 53 studies were included in the qualitative synthesis. This is especially on the AED delivery, where there was a cardiac arrest and AED delivery to the remote areas. And if you see here, the median time saved when the AED was delivered by the UAVs was 3 minutes in the urban settings, and in the rural settings it was 19 minutes were saved before an ambulance could arrive. It was that fast, right? And just look at this, blood delivery, again, vast difference could be noted, and the benefit in cardiac arrest. When the UAV assisted group, it was 30.2% who returned to ROSC, whereas it was only 17.6 in the standard care. So there was a lot of improvement, and oh my God, yeah. I'm not going into the challenges. Lot of studies have been done. What I'm trying to say is it is an evidence. It is an evidence, and I just looked up whether in India it is there. In India, in the northern parts, especially in the Himalayan regions, they are using drones to deliver the medicines. But AEDs and blood delivery hasn't come to India. But that's one promising thing that could be done. Imagine, today, large divide between the urban and the rural community. Right? So this would solve the problem, but lot of logistics are required, lot of governmental support is required. Okay, this is, oh my God, how do I play that? Can you just play that video? Okay, I just had a picture, meaning a video, a very short video of showing how the drone delivered the AED, and it is a Swedish study. I'm just skipping that. I'm moving on to the third creativity, okay? That is ED nurse-led code sepsis. I was talking to one of my friend who works, like in the UK with the accident and emergency. And she said, Devaka, there is a very beautiful code, sepsis code that is there in the accident and emergency. So I kept again, searching, and that is true. How this works out, and we need to remember whether it is in the critical care or in the emergency, sepsis is the number one killing thing. I remember my dad, and nowadays, we are talking about this, teletriage and all that. Way back in 2015, my dad called me one day, and, my dad is a very cheerful and a very bubbly person. And, he called me, and his voice didn't sound good. And I said, not even a video call. It was only an audio call. And I called my brother, and I said, there is something wrong with Appa. Why don't you take to Apollo? Because that was close to us. He was taken to Apollo. It was a Sunday afternoon. Imagine, a lot of goosebumps. Imagine having the knowledge and having the right technology helps in saving the life. He was taken into the ED, and, his BP was only 80/60. He was going into a septic shock. Rightly identified, 7 days of antibiotics, and he lived after that for 4 long years. What I'm trying to say is, sepsis kills many people, right? And this is again a systematic review. These are the key interventions in nursing-led code sepsis. There are 2 people. It is a cohort, a group of ED nurses, and, it is where it is automated ER. You put in the vital signs, you put in the investigations. Again, there is AI here, okay, but along with humans. So here what happens is, when there is some triggers, the alert is immediately sent. So once when the alert is sent, the team comes, code sepsis activation pathway, and the criteria is given in terms of systemic inflammatory response syndrome. I just put the criteria, but owing to time, I'm just skipping that. So once that happens, there is a multidisciplinary response where standing orders are immediate. She told me, we don't wait for people. We draw blood for lactate levels. We immediately check the urine output and, the antibiotics. Okay? And what happens here, and there is a phlebotomist and an RN nurse who comes, immediately starts a dual IV to Russian fluids to give antibiotics. That's beautiful because time is the key here. And, the sepsis task force, they also do an audit. This is the sepsis team. And with this, what happened is, look at the numbers. Everything has to be in numbers. We need to evaluate. There was pre-intervention from 13%, the mortality decreased to 9.4. Sepsis bundle compliance increased to 80%. Observed to expected mortality was 0.96%. Again, a reduction. This is the key for everything. Door to antibiotic time, pre-intervention, it was 218 minutes, where it decreased to 145 minutes. But that too, again, it should be less than 60 minutes. Within an hour, you should be able to. They didn't touch the standard. But still, there was a decrease. Okay, so that's an evidence. Okay, and target achieved. Again, this is lot of studies. What I'm trying to say is, beautiful evidences are available. Only thing is, how am I able to? Ma'am was telling, it is very difficult, ma'am. I do agree. We know all these are evidence. But to put it into practice, we need a lot of support from the government, from the administration. Okay? Yes. Yeah. Just a break. Who is this? Huh? Can you be louder? Oh my God. I was, traveling and I was telling my friend, okay, huge football fans here. Okay, at 5 o'clock, big screens and people sitting and watching. It really made, a lot of goosebumps, okay? So nice, okay? He's the youngest player, Lamine Yamal. Kind of, again, rewiring, right? You can't listen to. And who's this? Mbappe, right? Yeah. Which country? Oh, yeah, France. Superb, yeah. Lovely. One of the very, very, very demanding sports. Highly demanding, this one. Coming on to the fourth innovation, right? Hirad framework. I'm closely associated with this because, this Hirad framework, again, after TRIAGE, this is a framework which was, widely used in US, and now again Saudi, they have tried. And we are also taking up a study. It is in the proposal stage in Vellore, CMC Vellore, in the ED department. And the Hirad goes like this. History is collected along with red flags, assessment, interventions, diagnosis. What does Hirad stand for? History, red flags, right? Assessment, continuous assessment, intervention and diagnosis. And look at this. Again, this is a systematic review. This is in, this is again in Australia. Just look at this. Just look at the findings. After Hirad framework, where TRIAGE prioritized, but again you go back, check with the patients, keep looking for the red flags, keep looking for the alarming signs, and it has improved the quantity of documentation, also the quality of documentation, and not just look at this. The red flags were identified. The identification of red flags moved from 24.75 to 54.7. Very important. So you are able to identify the clinical deterioration. When you are able to identify the clinical deterioration, you are able to, give the right treatment. Hirad is all about that. We are learning something new. And India, we are going to try it out at Vellore, right? Already, ethical committee has given the approval. We are just waiting for that. And this is the person, who kind of, made this framework. And she says, we estimate the framework will help prevent deterioration in more than 5,400 patients when upscaled to all emergency departments nationally. Kate Curtis, Hirad framework, and she's an Australian. Again, this is yet another study findings. And I just wanted to say, so much of evidence is available. And it is coming up to India also. This is yet another newer framework that we are taking back. Fine? The fifth innovation, I've taken in different angles, not just with patient care. This is with the, again, the medication safety. I just love this, okay? Dedicated medicated nurse in the emergency department. We have medication nurse in the wards and all that. But in ED, in India, it is happening, right? And we all know, again, this is a systematic review where the rates, the prevalence of medication rates in ED is very high actually, because it's a tense situation, all life-saving medications, you are in a kind of hurry, okay? There are a lot of chances you could make the error. And there is a dedicated medication nurse. One of my good friend is the CNO who's working in the Kaveri hospitals in Chennai. And she said, ma'am, we have a dedicated medication nurse. She has brought in that change where That nurse is responsible for indenting the medicines, got it? Preparing it so that nobody disturbs her for any other thing. Because lot of distractions causes the medication errors. So these are the things, order verification, safety protocols, safe compounding, collaboration. So there is lot of workflow efficiency, reduction of errors. And so dedicated medication nurse is possible. A little innovation administratively that is brought in at Kaveri Hospital. And apart from this, there are also barcode verification, which will prevent in medication errors, automated dispensing cabinets. Very beautiful. I had a lot of videos, but owing to time, I'm not. You have to scan it. Only the medication, for you, it will open up. Oh, how nice, right? So that you don't make errors. The next one is so good, right? People working on the highways, you would have seen with this kind of dress. Again, here, for the medication nurse, we call that as no interruption zones. Very nice. So people don't go and ask, where is this patient? What are you doing? She is completely only for what? Medication handling. And clinical pharmacists in ED, this we had in Vellore, even way back in 2000 when I was doing my PG there. We had a clinical pharmacist coming along with us. Very nice, So, there is a lot of reduction in medication errors and standardized high alerts. Fine. Sixth innovation, okay? Workplace violence, very common in ED. Oh my God, crowd, they shout at you, they come and hit sometimes, right? All this happens, okay? Who is this? Yeah, doctor? Oh, I'm happy you remember her. When I put the slide, I just wanted to see how many people remember her. This incident happened in 2023, where she was stabbed to death when she was treating a patient. And recently, that person got the final verdict. Oh my God, it was heartbreaking. Today, she would have been a beautiful, very, very smart doctor. We lost her when she was doing her internship. Isn't that very sad? Okay, so workplace violence is very common. And what happens again, 5 to 12 times higher than any other workers, right? And look at this type of violence. It could be verbal, physical, or other forms. And physicians, nurses. Nurses are the highest ones who are targeted because we are very close with patients. And again, instigators, it is mainly the family members, then comes the patients. And 77% of ED staff are prone for violence. Okay, so just remember, again a systematic review this is, okay? I put all this because it is dangerous. We need all proactive and multidimensional, not taking actions after it happens, but I have to take actions before it happens. And these are the solutions. You can have predictive behavioral screening, dedicated behavioral emergency response team. We call it as BERT, right? I've given it in the pre-test and post-test, I think. I'm not very sure. Simulation-based escalation training, trauma-informed environmental care. And look at this, early detection will include behavior risk triage. When I am triaging itself, I need to kind of triage whether this patient is safe or if this patient has some signs of violence. That is very important. And we have a lot of scores here. Just look at that. ABRAT ED, Project Beta guidelines. We have system flags. Make that into the electronic records. And if there is going to be a history of violence, immediately kind of activate the BERT huddle. I'll come to it later. And then de-escalation rooms. Once when you know that that is a violent patient, you can keep the patient separately and watch over the patient, right? And the ABRAT is aggressive behavior risk assessment tool for EDs, violent event severity tool, behavior team, and beta is best practices in the evaluation and treatment of agitation project. So you can have a controlled access, buddy system, and clear signage. I'm skipping that. This is one evidence where they did a study with no intervention. Then they gave, based on the ABRAT score, they put in a signage, and later, along with signage, a BERT bundle. In the BERT bundle, we used to have a doctor, we used to have an ED nurse, we used to have a social worker, and a social security guard. We call that as a BERT bundle, and this proved the efficacy. The violence was 0.93, later reduced to 0.67 only with the signage, and with the signage and birth, it is 0.62. Okay, I'm just skipping that. What I'm trying to say is, when you have, I have time? Another 5 minutes? Ma'am, another 5 minutes? Yes. Okay. I'm sorry, okay? Yeah. Yeah, this is another one, hemorrhage control with trauma. It's there for 8 years, but I don't know whether in India it is applicable, okay? We call that as clamp it. Simple things, but even with carotid they have done, okay? Look at this. They squeeze it and put it, so it enhances a hematoma formation, it causes pressure, arrests bleeding till further intervention can be done, okay? Yeah, that is there. I'm skipping that. Yeah. These are innovations in other parts of India itself. In Kaveri Hospital, they have a stroke base separately for different diseases. So the medicines are organized. There is no wastage of time. Little innovations in the infrastructure. They have a polytrauma code and, stroke code. Even when the patient is in the ambulance, the information is given to the CT centers. The team is there so that the golden hour is utilized very effectively. And in US, in the UK, they use a score called as NEWS. That's called as National Early Warning Score. And based on the findings, they escalate the treatment. And one more interesting thing is the geriatric population is more. So they have a neck of femur fracture CNS, because they get a lot of patients with fracture femur. So they have a very specific CNS for neck of femur fracture. They have a liver CNS working in the emergency department. Stroke nurse, I think, even in India we have stroke nurses. Fine. And I just wanted to finish with this, just 2 minutes. This is one of our students by name Xavier Dixon, a very smart student. I talked to, this is what I was doing, in the past 2 weeks, getting information from all around the world, what is happening. He works as an air ambulance nurse. He has taken 574 flights and he has seen 3 crashes. He told me, ma'am, I'm really proud. Okay, and I talked to him, what are the innovations that you're making in that field? Because it is again with emergency and trauma. And just look at this. Simple things when a child is, kind of shifted. The straps around, right? It all didn't come out just like that. Simple innovations, right? And look at this. All monitors, everything there. And I had a video, I couldn't play that. All monitors in the aircraft, it is completely, nicely placed. Very easy to handle. Isn't that a great innovation? Yes, it is a great innovation. And, kind of sitting there and monitoring, documentation, everything is innovation there. Okay, because a lot of airlifting is done nowadays. And look at the kind of instruments or newer techniques they are using. Zoll Auto Pulse automated CPR device. If this is connected, the machine will give you the CPR in the aircraft. You got it? And they also have Auto Pulse Next, which is a sensor board which is kept under a patient, and it will give you all the details. Again, all AI assisted. Watch Pat 1, this we all know, right? And there is this I really loved it. Z-Vent. It is a very compact ventilator, less than a kilogram. So it can be easily carried. Right? And, all-in-one monitoring device. Everything can be monitored in one thing, and this is connected to the mobile. So sitting in one place, you can see everything. Right? Fine. Maldives emergency wards are, equipped with thromboembolizing center along with ER. And also, they have the CAT centers within the ER. Isn't that wonderful? And, because he's an ambulance nurse, all the innovations or the changes that is happening in the policies are trained through airport full-scale emergency excavation exercise, which happens once in a year or once in 2 years. All the innovations are incorporated and training is given. Right? And I had a video, I'm not playing the whole thing. Fine? Yeah. So future healthcare landscape will keep changing, no doubt about that. Okay, if you ask me to talk about education and all that, it is completely changing. So is our healthcare. And innovation will keep happening. But the question is, are you ready to take it up? Okay, that is what, from the comfort zone, you have to move to the, yeah, yes, okay, fine. Always have an open mind. Lifelong education is very, very important. New knowledge, skill development, and be flexible and adaptable. Don't be rigid. Don't complain. Don't murmur, oh, she's not right, this is not right, and I am right. Nothing like that. Yes? And innovate, be a change agent, and always look for care quality. And I would like to finish with this slide. Whatever you do, keep your focus on clinical practice. Okay? And that is what our nurses are called for. Okay? Yes. Knowing what's right doesn't mean much, but unless you do it what is right. Any questions or anything, any innovation you can add? This is my limited knowledge, and thank you for your patient listening. Thank you for taking some extra time. Thank you so much, okay? Yeah.
Thank you, ma'am, for sharing your wisdom and expertise with us. Your thought-provoking presentation has added immense values to this conference.
Now, I invite Professor R. Maheshri Madam to kindly come forward and present the token of love to Professor Dr. Devakar Bhai.
Thank you, ma'am. Next, we move on session 4. It's our pleasure to welcome Professor Dr. H. Juliet Sylvia, Principal of Sacred Heart Nursing College, Madurai, to the stage. Madam will share her expertise on the innovative strategies in community-based nursing care.
It's my distinct honor and privilege to introduce our esteemed resource person, Dr. H. Juliet Sylvia. She is the principal of Sacred Heart Nursing College, Madurai, and accomplished nursing educator with over 3 decades of experience in nursing education, administration, research, and community health nursing.
A gold medalist in MSc Nursing and PhD scholar of the Indian Nursing Council in collaboration with World Health Organization, Dr. Sylvia has served in several prestigious academic leadership roles, including principal, vice principal, professor, and head of the department.
She has published numerous research papers in national and international peer-reviewed journals, contributed to nursing textbooks, served as a journal editor, and has been an examiner, inspector, and curriculum expert for various universities and nursing councils. Her remarkable contribution to nursing education, research, and professional development have earned her wide recognition and respect. And a warm welcome to our distinguished speaker, Dr. H. Juliet Sylvia. Welcome you, ma'am.
A very good afternoon to all of you. Why so sad? I am very sure you are given a very high tea, a good tea break, isn't it? Okay, I'll try and skip slides to enable my next speaker do well. So I bring greetings from Sacred Heart Nursing College, Madurai. And I thank God for all the blessings which I don't deserve. And big thanks to my parents and to my alma mater, College of Nursing CMCH Vellore, which gave me the value education and which I am trying to be as a nurse. Then adding on PG in Homeology, College of Nursing and PhD. So I owe a lot to my teachers who made what I am today. Thank you, the pillars of this college, the principal, and Dr. Manjula, a very good human being, and for my coming here, the reason for my coming here. What is innovation? We have been learning much. I just want to highlight that innovation is something which is transformative. You have seen a butterfly starting. How many of you have caught butterfly, sorry. You have never played in a garden? Yes. So that is transformation, adding value to whatever you are doing. Okay, my discussion will be on what is innovation, innovative strategies, especially in community-based care. I just want to know which year you all are studying. Students, you have UG and PG students here, right? UG final year, BSc final year or what? Final year? Third year, okay. So you have been to community setting? 5th semester finished? Yes, very well you can then, okay. So whether you like it or not, now we are shifting towards people-centered care from hospital-based or episodic care to continuous care. So people-centered care, closer to their home, and preventive and promotive care. So starting from Nightingale's theory and Virginia Henderson's theory, nurses' main role is on health promotion and prevention of diseases. Okay. As you said, you have been to community posting. How many times you were only focusing on completing procedures? Yes? And now semester system is so packed, you have no other go. Within a short time, you are expected. If you go now, will you be remembered? This is the real scenario now. In the community, you find lot of elders just waiting for someone to listen or to be heard. That why innovations are required in the field of community health. Already all this has been spoken very much. You are in great demand. Nurses are greatly needed because there is rise of chronic diseases and you have much more to do. So quality patient care. Okay. Safety, digitalized education, continuous monitoring, digital record keeping. Okay. Who can be an innovator? What do I do or what should I be doing or how should I be? It is taking action when nothing happens. When nothing seems to be moving, you will go forward. Example is COVID time. We were the frontline workers. So instead of saying, oh, there is nothing can be done, you will be proactive doing something. So throughout this session, I will be focusing on what sort of innovations are required in the community. Okay. So at the center you find person, family, and community well-being. In hospitals, you will mainly focus on the person. But here, you are expected to know each individual and the total family and the entire community which has an impact on each each of them. So it is person-oriented care, equity and accessibility. In the first session today, we heard him speak. There is inequity, community participation, technology integration, evidence-based care, and interest. These are the core areas we require innovation in. First is nurse-led clinic. Do we have, or is it new? Way back in 90s, we had Conch Clinic, which was nurse-driven. Conch Clinic in CMC College of Nursing. It is not being practiced in many of the colleges or rural areas. So when you have nurse-led clinics, especially to manage chronic health conditions, can you manage hypertension and diabetes, the screening and the initial home management independently? Can nurses manage or not? Yes. Yes, we learn all the basics in first year. Yeah. So it improves accessibility and cost-effective care and encourages community participation and empowerment. Here is a case scenario. I have just few cases so that you can think of your care studies and relate it. Here you have a 55-year-old farmer, okay, who thinks his headache and dizziness is due to aging. Many a time, even a silent MI will be mistaken because they are not taught, especially diabetic patients. So, there a nurse-led intervention, a community health nurse conducts weekly clinic. She is able to pick up and then give an individualized counseling. The outcome is, his BP was controlled. He was able to have a healthy lifestyle. Second innovation is telehealth. I think most of you know it. Here also, it is a rural, it is a hilly area, tribal area. I don't know whether you have exposure to slum areas, tribal areas, apart from rural and urban. So, this diabetic woman had a wound which she neglected. They walk barefooted in the field. So, she has never linked it with the diabetes. Because there was telenursing available, who's Asha? Yes. Accredited social health activist. Very good. Why are you, you don't have to have any fear here. None of your teachers are here, I think. Faculty community health specialists are here? Yes, okay. So, she could link through telehealth, she could link with the diabetologist at PHC. Now we have Ayushman Bharat. What is Ayushman Bharat? Okay, how are the PHCs called now? Anybody? One of you. How the centers are renamed as now? Health and? Very good, very good. I could hear a lot of good answers. What about the boys there? Are you all awake? Yes, then I want answers from back now. Okay. So she was healed because she was able to connect with the diabetologist and he could see the wound and suggest the solutions for it. Okay. I'm not reading each and everything. So this telehealth has all these benefits. You can minimize unnecessary hospitalization, reducing costs, you can track patient, educate patient. Totally, it improves the health care. The patient need not travel. They are very safe at home. You don't require a caregiver at home. They are able to interact and do better. So Asha is there, a nurse is there, that CHN is able to connect. Okay. What is the platform which is using this tele-service in India called as? Anyone? E-Sanjeevani. You all are PG students? Very good. Okay. E-Sanjeevani. Can we give a clap for them? Yeah, national level. So that is an innovation. Indian level, the whole country is experiencing. Okay. This is an evidence-based study which says how effective is telehealth? I'm just reading the critical review findings alone. Okay, so there was reduction in hospital readmission. Admission with another complication added on. Here there is better satisfaction also. Okay, so we encourage telehealth in nursing. Okay, I asked the first question, many of you answered. Now, this last question to the last row students. Second question. Anybody from... Wonderful, wonderful. I didn't want your answers. Telemanas. Okay. So this is telemanas. Expansion of telemanas from that side. MANAS stands for? Anyone? Anyone come up and say? Is it available in India? What is it for? Mental health care. Okay. So, this online mental health improves, reduces stigma. Stigma and discrimination are different. Both are adding to, lower accessibility of mentally ill patients, or they don't come forward. The family is also hesitant, and this online mental health is able to give them remote counseling. Even adolescents can access. Okay. Next is home-based digital care. This is something which is available in many other countries. Many of my classmates are doing home nursing with the tele-facilities. They are the nurse consultants. Some of them are nurse practitioners. A nurse consultancy role by doing home-based digital care. So what is the advantage? Delivers healthcare information. There is more involvement of the participant, clarification. The doubts can be clarified by the person individually. Digital records can be accessed, etc. On the whole, it is connecting people and healthier communities. There is another case vignette for mobile health. We have not got home-based telehealth still, a home-based nurse consultant, but this is available, mobile health. One example is antenatal women being tracked. Because of that, she is able to get appointment reminders, medication alerts, health education, teleconsultation, health record. Now, at present, what is happening in Tamil Nadu is they are able to give a number to every antenatal woman so that she is registered, she is immunized, and she is given the financial benefit of the government also. But we can further add to all this. If she is anemic, her education can be given. She can clarify high-risk symptoms. She could report to the A&M, and A&M will alert to the doctor. Thereby, many of the high-risk conditions can be identified early. This is wearable technology. Do we have? Yes, some of us use, yes, but still not come to the rural people. Yes. So these are some of the devices you can use for fitness tracker, continuous glucose monitor, and portable ECG. And what is the effectiveness? The evidence says, physical activity is increased. Maybe older adults, all the time alone at home, nothing to do. If they have a track like this, they will know how many steps they have done. And it encourages them to be more active. Thereby, NCD complications are minimized. So I'm only highlighting the important findings. Here also, this is wearable technologies for health promotion and disease prevention. It gives them alert. Thereby, early warning signs are identified and referred immediately. Okay. This is also a systematic review. So, elders are empowered. This is remote patient monitoring system. So, here a patient after admission, so after discharge, you can always review them. When to come for the next checkup? Are they taking the drug? How are their BP recordings? Instead of going to the hospital, this is connected to the doctor who is at the hospital. Thereby, their transportation is minimized, and whatever doubts they have, suppose they have some drug reactions, immediately this can be notified to the doctor. So this is the benefit of remote monitoring system. Here a vignette, you see a old, 63-year-old man having hypertension, and his reading is monitored. The CHN, it is connected to the community health nurse. Okay, she is able to get certain alarm sign if there is any reading abnormal. She is connecting with the teleconsultation physician. Okay. So all this, apart from that, this mobile health care. I don't know about this in Kerala. In Tamil Nadu, the previous CM introduced Makkalai Thedi Maruthuvam. Okay. So there all the facilities are available. In fact, even cancer screening is tried out by certain private hospitals in Madurai, where breast cancer screening is done by them. So mobile van availability, you can use for eye, dental, immunization, child health, all that. So reducing the rural-urban gap. Okay. All these are some of the examples which a nurse can use certain technology in her care. These are the benefits. Better satisfaction, the work is efficient, and cost is reduced. Okay. This all of you are familiar, electronic health record. I'm just skipping. Next is community health information system. Now, every information is available just by one click. What is happening in Tamil Nadu can be accessed at a national level because it is connected with the health management information system. For all this, who's the backbone? Collecting data, who does? Who? Nurses. The ANM and the CHN who is available. So we are utilized for the data, but we are not recognized. That is another part. But you have to be proud that this gives evidence for our future changes in the policy or administrative level. This is the Pygmy app practiced in Tamil Nadu, where every ANM is registered. She is given a number, and any DPHN, district level nurse, can access it. She can find out how many high risks are there, which visit they have missed, all that. My Service Provider app. This is connected with the ANM. Okay. Next, another one is digital disease surveillance. So we have lot of epidemics coming up, and this will help us to point out which is the risk-prone areas, which is very common. Among the districts, which area is highly affected. You can check the outbreak earlier, thereby prevent the transmission across people. Okay. What is this Nikshay portal? For TB. You know the meaning? Ni means nai. That is no. The second part is denoting TB. So this is one way of tracking TB patients. Okay. After this Nikshay app has come, there was a reduction from 15 lakh to 2.5 lakh. Isn't it amazing? Just one new technology brought in a reduction in a killer disease which we have been struggling and still struggling with the resistance. Okay. Another one is digital immunization. Give example of digital immunization record. We had during COVID. All of you have certificates? Yes? That time, okay. So now many other diseases are now going into this system. This we can track better, and the immunization coverage of each state can be checked. So after smart vaccination technique, this has become faster, improved vaccination coverage. So this helps in bringing down the disease rates. Okay, smart vaccination tracking system. What is the newer vaccine which now adolescents are expected to take? Why those groups are silent? Answer? Any answer? For HPV, yes, it stands for human papillomavirus. Okay, very good. Anyone come forward and say, name the digital platform mobile app launched. Anyone come for, who answered? No one answered. This is you win. Okay, national level you win. No, even if you are wrong, no problem. You can just answer at least. Okay. What is this mission Indra Dhanush? Anyone. You will get a prize if you answer. Indra Dhanush Yojana. Okay. You find a rainbow, no? That is why it is called as Indra Dhanush Yojana. So, previously it was 6 killers, now it is 7. Now added on 12 diseases. Okay. So, we have 12 vaccines available. Okay. One small innovation against diarrhea is, yes, rotavirus vaccine. Very good students you have, ma'am, PG students. They are answering so well. Okay, rotavirus vaccine. Okay. And oral rehydration solution. Ma'am was telling, she has more than 30 years. Those days, ORS corners were, we established ORS corners in every village. A volunteer was trained. Okay. So these are some of the diseases. So on the whole, it's just a nutshell. I have focused on innovation done by our government of India. Okay. Many of it you know. National Rural Health Mission, Ayushman Bharat. Okay. E-Sanjivani. Just now we had all this and tuberculosis elimination program. Okay. Now what else we need? I was summarizing what have been the changes which have come into our system. Now, what are some of the gaps, the areas which require some more innovation? One is rehabilitation. Disabled people are neglected. This is one case scenario where a 16-year-old boy, after an injury, spinal cord injury, you can imagine what would happen. But because the community was able to give support in terms of environment, in terms of giving an employment, skill training, education, and health workers provided him physiotherapists, nurses, and nutritionists, he was able to have a healthy life. But we don't have an established rehabilitation program available for all age group. Okay. Next is community-based palliative care. Kerala is a role model for this, and now Tamil Nadu is slowly integrated into PHC in certain districts alone. So a nurse is doing, but all VHNs are trained to screen for cancer cervix. What is the test done at the primary level to screen for cancer cervix? Anyone? I didn't get. Why one of you can tell me? Pap smear is not done by the ANM. She may take it. Before that, preliminary diagnosis via villi test. Everyone is trained. Okay, then they advise for pap smear screening. Okay. So now still gaps are there. Palliative care is a very demanding area now. We have more and more cases of cancer and different terminally ill people are there. So the hospitals will not be able to tackle all the issues faced by them. So nurse can intervene we are the ideal change agents. We could do much in this. So what I want to say, a community health nurse has to be knowing all the field, medical surgical nursing, MCH, pediatric, all mental health, everything. Okay. Now in PPH, to control PPH at primary level, we have one intervention. Do you know? Why don't you be louder, or somebody can pass the mic? Bimanual compression using hand. That was what is practiced very long ago. Any other innovative devices come? Okay? Suction, no. There is a non-pneumatic blanket, belt, which is tied at the PHC level. If a mother who is delivering starts bleeding profusely, immediately this is tied. Sorry, I should have brought the picture. Thereby it shifts the blood to the more essential organs, the more vital organs. Okay. Yes, we have improved our health system. The technology has come in. There are a lot of challenges in the present complex health system. But amidst all that, are we kinder? Core values of nursing, are they forgotten now? Are they able to see a nurse who's exhibiting? Will you get a compliment from your family after you finish your care study or finish your family visit? Especially if there is an oncology client at home. Just check. Okay. Next area is community mental health care. This is also a growing and demanding area. You have one side adolescents with a lot of drug abuse, elderly with depression, all that. This is in Umayalachi College of Nursing. They have a clinic called kiosk. Kiosk is like a grocery shop. Here and there, few volunteers are trained where all the hypertensive diabetic patients come. Monthly they are monitored. Their depression and insomnia symptoms are also monitored. So it is you are screening for other comorbidities, and they are given mental health as well as to take care of their physical part of it. Next, another important area is school health. Few days ago, we went to a school, lot of complaints saying, can you do something for the parents? Can you do something for the... Do we have adequate school health nurses? Or is the nurse sitting in the school equipped well to handle the issues which are coming up? Yes. Who's there sitting as a school health nurse? How many of you are willing to work as community health nurses or PHC nurses rather than ICU nurse or trauma nurse? Isn't it? Yes. So now in Telangana, they have a project called Health ATM. So where, they have a screening, okay, mental health club, nutrition program, health screening, digital health education, and also a counseling. The child can just browse in, can go in and throw her questions. Through telehealth, she can be connected. Thereby, more privacy is needed. WHO is recommending youth-friendly centers. Do we have clinics available for adolescents who are sexually abused or who want some reproductive health counseling in a private area? So the next is workplace. Occupational health, industrial health, even in companies where stress management, few companies have absorbed nurses, but we need few more industrial nurses. I'm not talking about very big companies alone. In rural area, different occupations. Our college, med-surg department, they have undertaken lot of studies. one for farmers. And now they are training drivers, auto drivers for trauma care. And we have one student doing in petrol bunk workers, teaching. So you go, be with them, you will learn many. And I have lots to do. So this is a study done, this is a project done in a Tata Steel company, workplace intervention. What about nurses? Care of nurses in their own workplace. Do we have creche in the hospitals? Are our nurses cared enough? Okay. This I'm skipping. We need interprofessional collaboration and community health nurses who are willing to collaborate, work as a team member. Yes, individually you can do excellently well or excellently doing your job well, but are you willing to collaborate with other professionals? Okay. This is one Dutch model which is talking about nurse practitioners, nurse clinicians, all as a mobile team, having high autonomy, whole person focus, continuity of care. Maybe you should have an oncology nurse, a trauma nurse, a diabetic nurse like that, who are visiting the village. Any gaps, maybe morning one OP can be conducted by a palliative nurse. Something like that, if that comes, this Dutch model, if India it is coming, will be more recognized. Okay. Family-centered care, is it new? I feel it is not found now. It's only in books. Family-centered care. You will have a member with a TB, another antenatal with anemia, a child with malnutrition. What sort of care we are doing? If I am a 5th semester, I'll take care of the child, only malnutrition, teach and come. What about the TB client? Have you done contact tracing? What level of prevention that is? Secondary level, okay. So we need to go to the basics, that is family-centered care, where you are able to give to every family as well as giving a total family approach. Thereby emotional support, adherence and all is there. So this is another home-based care scenario. Due to lack of time, I'm just skipping. We have to do home assessment. Now, any PG student, if they take care of elderly, what I tell them is, do a fall risk assessment, nutritional assessment, hypertension, diabetes, and communicable disease screening, as well as depression and many other mental health. So thereby, individually, all the aspects of health are identified. Whichever supportive care is required by other professionals, you will call in and do it. Okay. This is a question we have to reflect. At the end of every posting, are they really needing your care? Is there a demand for home health nurses? Or do they feel, are they comfortable? Okay, we think only our technology is making a change. Even a kind word can change. Another is innovative health education models. What we try to do is now application of health belief model, proceed model, lot of models, behavioral change communication model on all there. This is a lactational nurse. Nurse who's doing midwife, who's doing maternity nursing, can do an additional course in lactation, and a peer education can be tried. Peer-to-peer education. Okay. These are some of the studies where they have found interactive education workshops and community clubs acting as effective. Creating community clubs, elderly clubs. We tried out yoga therapy, laughter therapy, created community club. Okay. Next, another word is community participatory model. Are we including them in every decision? This is a kind of self-help group. The mother group can be your focus group. You conduct research, a preliminary step, you can do a focus group discussion for your tool or intervention. as well as you can train the more influential person, they can transmit their next to others. So this is a community participation, one way of participating in the community. So the key word is whichever strategy you want to do newly, you will engage the community members. They are partners in healthcare. It is not we providers and they are as recipients. They are engaged in every step of our care. Thereby sustainability is there. The most common issue is non-equity. Second is sustainability or long-term stay of whatever intervention. Maybe for some research we do and come back. Who's there to continue and follow up? Unless you have trained someone. So, we are now here. We should move to community driven. Rather than curriculum focused or fulfilling our requirements or we want to do something, it has to emerge from them. What needs are there? What are their actual problems? So we should shift from transactional to transformational. Okay. This is one model called ABCD model, assert based community development. So it is inside out and bottom up instead of top down approach. What is this assert based model? Instead of looking at the community as, oh, that area doesn't have this. Normally, we tell them to make community diagnosis at the end of survey. And we list out all what is not there. But look at what is strong in them. Try to strengthen that. Thereby, every individual, what is good in that area? What are some of the resources which I could utilize to make the community better? So, we have been only the decision makers. Slowly now we have tried to involve. The shift has to be they playing the key role and we as the backsiders to support. Next is evidence-based framework. The steps of evidence-based so I have skipped. You take research evidence, practice evidence from the experts, community health nurse specialists, and who are working in the field, people's evidence. Collect their beliefs, then the local environment. What suits in America will not suit India. So please utilize all these 4 evidences. Now, how do I go about while doing an innovation? We all do community mapping. These are some of the steps. Forming groups, selecting community, draw conclusions, identify the gap, do a group presentation in front of them. They are doing this work along with you. What is the problem? Which is more important? They reflect, then finally, innovate locally. You cause a change in one village. That will affect the nearby village. Then it starts moving the entire district, then again, entire nation, and then global. So we can start with this project. Last year we had our UG students doing a climate change. Now, more than health problem, the root is here. Root is here for all major health problems. Okay, I'll finish it. Okay, so for a climate change, you can involve community members doing something about it. Okay. So, how to bring transformation? We as innovators, we need to move for empowering the community people, underserved populations. These are the key responsibilities. We need to improve in advocacy role. Maybe we are doing this better. Collaboration, yes. Technology integration, slowly they are trying to do. Okay, collaborating, monitoring, etc. Okay. Just check, we can check each of us whether we have all these skills. We say we have AA, and ma'am clearly said AA can be an assistive tool. That cannot take the prime role. At the same time, we cannot escape. We cannot be illiterate. Okay? What is needed is humanizing healthcare. Make them feel a personal touch. So I would feel our grassroots have to be strengthened. The basics have to be strengthened. We need to be resourceful. Ma'am was giving example. In community, we need to utilize something what is available. A snake bite, you can't be running about. What can be done at that level? Okay? Then think of what can be designed at the process level. I don't know how many of you know them. They are from Kerala, both of them. She is my teacher. He is a community doctor. Trained in CMC, went to a place in Orissa who could transform the health and heart. How? When he went there, there were a lot of malarial deaths. But within 1.5 months, they were able to bring down. Even WHO was amazed. How could they bring down such a, drastic reduction? It was because he was able to do field work, train people there, and they could make the people understand the psychology of malaria, psychology of the mosquito bite, how the mosquito behaves. Thereby, the whole community was prevented. If you want, you can just go and refer websites, YouTubes. He is Dr. Johnny Woman. He has done many innovations. For his son's wedding, the whole village celebrated, it seems. Reduced a lot of postpartum hemorrhage. They made it as a homemade wedding. So, you as an individual person can make a simple change which will have a rippling effect. You may be thinking, how will I change the whole 5,000 population? Not necessarily. Not necessarily. Okay? This is a question for the faculty. Yeah? INC fulfilling hours. How are our students engaged in real learning? And we could use certain virtual learning experiences. Maybe in future we will have robotics. Okay? We need to shift for self-focused care and collaboration models. These are some of the barriers. Again, I'm finishing with the last slide. They are the centers, and if each of these aspects are taken care, innovation is possible. Okay? These are some of the examples. Technology with compassion together drive the future of community health nursing. What makes an ordinary nurse? You want to be an extraordinary nurse? Instill this in your care. Thank you for your patient listening.
On behalf of organizing committee, I extend our heartfelt gratitude to ma'am for your remarkable and insightful section. Thank you, ma'am.
Now I invite Professor Dr. Manjula Ma'am, Program Coordinator, to kindly come forward and present the token of love to Professor Dr. H. Juliet Sylvia.
Thank you, ma'am. We are now moving on to the next session. It's our great pleasure to welcome Professor Jenny S., Department of OBG Nursing, Christian Medical College, Vellore. Madam will share her expertise on the innovative approaches in maternal care.
It's my privilege to introduce our esteemed resource person, Ms. Jenny S., Professor and Nursing Manager, Christian Medical College, Vellore. With over 20 years of experience in obstetrics and gynecological nursing, she is an accomplished educator, researcher, and administrator. Her expertise spans maternal and newborn care, midwifery, nursing relationship, and evidence-based practice. She has published numerous research papers, received several academic awards, and has been mentor to countless nursing professionals. A warm welcome to our distinguished speaker, Professor Jenny S. Welcome you, ma'am.
Thank you so much for that introduction. And I know that I'm placed in a very crucial time of the day before your lunch. So it's an honor for me to be here right now, to be a part of this conference. And I would like to thank the principal, the organizing team for the opportunity given to me to share my views on innovations in maternal care. I can hear something. You know what? All your tummy is churning. Is it true? Yes, I know. I know that you're all in great distress. But one good news I'm going to tell you that whatever I have to cover, my previous speakers have already covered. So I promise you that I'll finish it in another 15 to 20 minutes. You can count on me. Okay. So before going into the topic, I would like to bring greetings from my place. This is my place, College of Nursing, CMC Vellore. And we have just celebrated our 125 years of our hospital. So when you come to Vellore, Tamil Nadu, Vellore, you're welcome to come and meet us in this campus. We are in 7 campuses right now. So moving on to what is innovation without taking much of your time. Innovation is a very broad topic. The definition differs from one person to the other. So it has got broad perspectives. It has got broad ideas. So sometimes whatever is common in urban might be an innovation in the rural area. So it is like all the previous speakers said, it's high time for us to change our mind. Our mindset should change from where we are so that we can push forward our profession, especially the maternal has become obstetric nursing now. So like how the term has changed, we also have to move on and make sure that we move into a zone of innovation, which is nothing great, but a change in a policy or a process or a product or a program which is mainly aimed at bringing a better patient outcome. So innovation is nothing but having a new perspective or a lens in solving an existing or a current problem. So it should be mainly for the community. So you need to the person who is evaluating innovation should always be a person from the community, and it should be very applicable for them. Okay, there is a critical need for innovation because we know, if you see for the past 2 decades, the maternal mortality and the neonatal mortality have drastically come down, but we are still having increased incidence. Even it has come down so much, yet these gains are not very distributive in nature. It is very uneven. So if you look at our current maternal mortality and newborn mortality is still high, and we have a global shortage of nurses, global shortage of midwives, and also the high-risk pregnancies are increasing. We have around, if you take 100 pregnancies, out of that 30% of pregnancies are with high risk, and out of that 16% are with some amount of high risk, which is multiple high risk. So we need to definitely move ourselves, push ourselves for innovation. Maternal care is not just like a disease which happens at a particular period of time. It is a continuum of care, starts from preconception. Okay, then we have antenatal care, intrapartum, and postnatal care. So the entire continuum is there. So we need to have a framework where we can cover from the preconceptional care to the postnatal care. So this is the framework that we have to work on. The main core objective of innovation is you have to make sure that the outcome is safe. The mother and the baby comes out safely, and it also provides a good experience as they go through the continuum of care. I know I am rushing because I'm favoring all of you to have good lunch. Okay. Now we look at certain digital innovations. Especially I will just focus on whatever we are practicing in CMC. The first thing is EMR. So everybody, I know that most of the hospitals are practicing electronic medical recording. So when a patient comes to the OPD as an antenatal, we put all the data in the computer, we feed all the data about the antenatal, all the parameters, all the investigations, everything that is there, the history. So every time when she comes for an antenatal checkup, the informations are recorded inside the computer, the electronic mode. And once she comes later on to the delivery unit, those data are also there in the postnatal even after discharge as a postnatal, when she comes for a readmission. So there is a continuity of care. When you put her hospital ID or a hospital number, the entire data of the patient is accessible for the healthcare team who is going to give treatment. So there is an electronic medical recording that has been followed in our hospital. I'm sure that it has come across everywhere. And also there is an integrated maternal tracking system which has been initiated by our government. We have a wonderful maternal tracking system by the government, that is Ministry of Health and Family Welfare. So where in Tamil Nadu it is called as PICME. Ma'am has already spoken about that. PICME is nothing but Pregnancy Infant Cohort Monitoring and Evaluation System. When an antenatal registers herself into the portal, when she comes for the first visit, all her details are available. She gets prompt messages, she gets her next visit due date, she gets health information related to pregnancy. So everything is, like ma'am was telling about the app, she showed a picture of the PICME app also. So this is one of the integrated maternal tracking system. The next one is virtual consultation, thanks to COVID and the other aspect where everything had become virtual. So from the time COVID started, most of the consultations happened virtually. I would say that in our hospital, we have lactation consultation. We started it virtually during the COVID time, and even now we've got some education which happens virtually to the clients. A postnatal client, after she gets discharged, she can contact the lactation nurse either by a phone call or there is a video conferencing. We also had parenthood education which were given virtually, but now since they're all coming on site, it is not very actively going, but virtual consultation happens in our obstetrics and gynecology as well. Then there is a continuous remote patient monitoring has been already talked about, especially a patient in the remote area. She's given some wearables, all the parameters, biomedical parameters are entered in the app, and that has been evaluated by the nurse or the doctor in the parent hospital, and decision or clinical decisions are given to the patient. There's a study which is done which says that overall these things are feasible, but then there are challenges for the doctors because for them they have to see patients on site and also have to deal with the patients who are coming online. So the workload becomes more, and the patient also becomes more anxious after sending the information, after looking at their parameters. They're also getting very anxious. Sometimes the digital technology gives inaccurate measurements, and the cost is very high, and not everybody is tech oriented in the rural area. So those are some challenges. This is our labor room centralized monitoring system. Our labor room is actually a 30-bedded labor room. It is not like a second stage room. It is a 30-bedded, full-fledged LDR type, labor delivery recovery happens in the same bed. So we have monitors for every patient. Continuous fetal monitor is placed for every patient. So doctors cannot be at the bedside most of the time. Sometimes if they are attending another patient, it becomes difficult for them to monitor. So we have a panel here. If you look at this picture, you will know this is a frame where all the bed numbers, CTGs are captured. If a doctor wants to see this particular patient's CTG, they can go and click onto this, and this will open, and they will look at the trace. The empty ones are where the intermittent monitoring happens. They are not on continuous monitoring. So CTG traces can be monitored from a centralized area. This is not seen in very many hospitals, but this is what in CMC Vellore we follow this. So when you see the centralized monitoring system, a registrar has a doubt, she calls the consultants, and this is incorporated into the electronic medical recording system of the patient. Even at discharge, if you want any clarification after a C-section, if you want any clarification regarding the trace, it still comes online. So the software is available. It is attached to the EMR, that is electronic medical recording. Artificial intelligence and predictive. Many people have talked about this before. So one thing I wanted to tell about is this AI can predict patients who can become preeclamptic or diabetic. We have something called as placental growth hormone which has been detected. So this identification of this one in the first trimester can tell that whether this mother becomes a preeclampsia in the later stage. So prediction of preeclampsia can be done so that with this biomarker. And automated ultrasound analysis, we have a unit called fetal medicine. So this fetal medicine is the one which deals with a lot of congenital anomalies and fetuses with birth defects. So in that unit, they have a 3D and 4D ultrasound, and it cuts the images very precisely, and it gives a very better visualization. That is only available with us for now, but there are other methods. AI incorporated ultrasound methods are also available, where an AI can look at the fetus and identify what birth defects the fetus has. So that is not in our hospital yet, but the Western countries has these things. Okay, and there was a study which says that this automated ultrasound, around 48% of maternal complications were identified when all the details of the mothers are entered by EMR. And also there is 29% it can predict the complications using medical imaging. 19% it uses genetic markers, and 4% using other medical features. So it can be incorporated, AI can be incorporated into these ultrasound techniques and other EMR, so that prediction can happen. Evidence-based recommendations also is aided when you want to make a good, sound clinical decision for a patient. Your own judgment can be complemented by the AI integrated or EMR techniques which are available. The other one is wearables. Already spoken about this. Wearables are nothing but a patient can have a smartwatch. All the biomedical parameters can be monitored by the patient. It can be fed into the app, and it can be accessible for the healthcare team to see, and they can get the alerts, and they can tell, like how the first speaker was telling, that the messages go to the patient where they have to come and see a doctor. All those things are available. We also have continuous glucose monitoring. We have done a study in CMC Vellore where GDM mothers are given a smartwatch. They are asked to do 30 minutes walking every day, and they are supposed to do a sugar monitoring. Those parameters will be monitored by the person who's in the hospital, and decisions and recommendations and teachings are given based on those. This is the health app, which is also talked by the previous speaker, so I'm not going into detail on that. There are some interesting apps which is given by our government, which is called Ask Navi. Have you heard of these things? Okay. This is an AI-powered reproductive health access and education tool which offers personalized guidance mainly for contraception, family planning, and sexual health. So if you have any doubts, you can Google onto this. Put some questions regarding family planning. It will give you answers. It will give you. So this is piloted in Kenya in 2015, and it is now currently operating in Kenya, India, and Nigeria. It has reached around 1.95 million users, and it has facilitated over 9.1 million health-related conversations across Kenya, India, and Nigeria. The other platform is Asman, which was launched in India in 2017. It provides this helps the clinical people, especially healthcare providers, with clinical pathographs, helps in decision making, and it also gives real-time monitoring tools for the healthcare people, so that it helps them in handling patients and managing patients. It has helped around 266,000 deliveries and have significantly improved the adherence to clinical protocol, mainly in adherence with the active management of third stage of labor protocol, like a safe delivery app, but it is not so. It is another app which is really helpful for the healthcare workers. The other one is the Dava Mom. This is an AI-powered maternal care. Mainly, this is seen in South Africa. Okay, this has supported over 5,000 mothers and facilitated more than 10,000 chat interaction. So any queries, it is related to maternal health, okay, pregnancy and newborn care. The other one is the Moms Connect, which transforms maternal health through mobile technology, mainly through WhatsApp